Thank you very much indeed, Susan, and thank you, John, for inviting me. I'm really honored to be here. I gather I'm the only overseas guest, apart from Neil, but I don't think you can call Neil an overseas guest. So I'm going to give you some personal reflections, and I bring you greetings from Oxford. Sadly, this is my disclosure slide for commercial interest. So some of you, perhaps in the audience, are old enough to have known Jeff Chisholm. Jeff Chisholm was a very well-known urologist and professor of surgery at the University of Edinburgh in Scotland. And in 1993, he wrote this editorial in the British Journal of Urology. And I've just picked up one sentence where he says about prostate cancer screening accepting the consequence of PSA testing, which was going way beyond screening. It must be clear that this debate cannot be resolved because there has never been an appropriate trial either of screening or radical surgery or no immediate treatment. Indeed, until randomized trials are performed, we will not know if early detection with or without radical treatment improves cancer-specific survival. And therefore, the early 1990s were plagued with lack of evidence. No evidence that PSA testing and treatment of localized prostate cancer improved survival and or quality of life. There was an increasing burden to healthcare providers and society, which is now felt everywhere. Uncertainties for patients over what is the best treatment. Treatments were not being compared head to head. And this is caused what has been talked about earlier today, so I won't dwell. Huge discrepancy between incidence and mortality, as you can see here across the world. Increasing incidence in countries which do not have a PSA testing program. This is just UK figures going up. And an increasing incidence also in countries where, in the Far East in particular, where it is known that prostate cancer is not prevalent. Causing these three new terminologies really of over-detection, over-treatment, and under-treatment, and I prefer to use the word over-detection to over-diagnosis because you can never over-diagnose a cancer, but you can over-detect it. So let's go back to the patient. In 2017, what does a 50-year-old man who's worried about prostate cancer want to know? Well, firstly, he wants to know whether he needs to be tested for prostate cancer. And I'm sure you see, and we certainly see in the UK, Well-Men Clinic, where healthy men are pushed to having PSA tests without any discussion, without any counseling, and then it's a snowball. Then the next question is, how should he be tested optimally? And we heard today the variety of biomarkers and tests which are increasingly available. But perhaps not all very well validated. How accurate the tests are going to be, and does he have prostate cancer? Then he'll want to have more detailed information about the cancer itself. Basically, he wants to know whether the cancer is going to kill him. So Peter was saying quite rightly earlier, what we're looking for is not so much prognostic, but more predictive markers. Then he wants to know what the best treatment is going to be to prevent him from dying of the cancer and from suffering as consequences of the disease. He wants to know what the advantages and disadvantages of the treatments are, what's on offer, including the level of our expertise. And whilst we used to be put on a pedestal, we know what we're doing, and everybody's doing it very well, patients now come, and they didn't used to in the UK, and they say, how many of these have you done? What are your results? And the government now is pushing us to making it compulsory to publish our own audited data. What has been neglected, I think, over the years is investigating the balance of risks and the trade-offs when making management and treatment decisions. And these will be very different from man to man. We cannot assume that two men, different circumstances, different personalities, will have the same trade-off mentality between the cost of receiving a treatment, what type of treatment, and the advantages that these treatments are offering. Now, what do the health providers want? They want us to offer the patient the ideal treatment, which cures everybody, is given as an outpatient, has no side effects, and costs nothing. And we've been trying all morning to try and find out which of these treatments is going to be, and I think we failed. So let's just rewind the tape and see what have we learned so far from RCT, and there's been very, very few of them. This is SPCG4, and the data 20 years on median follow-up continues to show differences in favor of radical prostatectomy compared with watchful waiting in terms of disease-specific survival, all-cause mortality, and progression to metastasis. But the population of men who were recruited back in the 1980s doesn't really resemble too much the population of men that we see in our clinics today. Tim Wilt has just published his updated series on Pivot, and we've talked a little bit about it, and John mentioned that in fact there are differences that are not statistically significant. But I think what's mitigating that is the huge all-cause mortality that in that particular series, as you can see here. These patients had a lot of competing comorbidities, and I think this is possibly diluting the effect. So we've put our grain of salt in the soup, and we started back in 1999 the Protect trial, which is a major two-component, major PSA testing program mimicking screening and a 3-arm randomized trial of treatment effectiveness in prostate cancer. Active monitoring, which is a form of surveillance versus surgery versus radiotherapy, with a primary endpoint of disease-specific survival at median 10 years, secondary endpoints of all-cause deaths, disease progression, and most importantly, patient-reported outcomes. For 15 years, I was praying every day that surgery might look better at the end. And of course, I was disappointed. As you all know, these are the outcomes that we found. At 10 years median, 10-fold less disease-specific mortality that we expected when we wrote the protocol in 1996-97, so 1% disease-specific mortality with no differences between the arms. 10% all-cause mortality, twofold lower than what we anticipated, and a 50% reduction in metastases and disease progression with radical treatments compared with active monitoring. You've seen this slide earlier, and you can see that at 3 years, typically, approximately 25% of men drop out of active surveillance. At 10 years, 55% do. But as was pointed out also earlier, 80% of the men who stayed on active monitoring have shown no evidence of any disease progression and avoided the side effects. So we were not allowed to look at numbers needed to treat regarding mortality because we showed no differences so far anyway, but we did calculate how many numbers we need to treat to reduce the or prevent 1 man from developing metastasis, and it's 27 radical prostatectomies and 33 men were treated with radiation, and we need to treat 9 men with radiation or radical prostatectomy to prevent clinical progression. What about quality of life and symptoms? As expected, surgery causes most of the urinary and erectile function symptoms, but we also found out that these symptoms appear even in the surveillance arm because it's a function of age. And this is bowel function, which is affected by radiotherapy more than the other arms. Some of this returns back, but not going back to baseline. In terms of anxiety and depression, we found that also no differences between the 3 arms. And my hypothesis really is it's because it's not the treatment that causes anxiety and depression, but it's the diagnosis of prostate cancer itself. Now, have all these trials put together, including the screening trials, which I won't mention now because they were mentioned earlier, has it had any impact in what's happening in the world? Well, I think they have. Because if you remember, in 2011, the US Preventative Service Task Force gave a recommendation of D against screening, and that caused quite a bit of uproar, and many of you here wrote very eloquent editorials in journals about that decision. Now, in May of this year, they published a new draft recommendation which went out for consultation, taking into consideration all the data that I've mentioned to you before, updated, including Protect. And there is a shift in that the D recommendation is staying, but for men aged 70 or older, but the C recommendation is now being suggested for men between the age of 55 and 69, insisting that they should be counseled. So I'm going to address in the next few minutes 2 critiques and 2 questions that have come after the publication of our 2 papers in New England last year. The first one is the perception that the Prostate cohort was mostly low-risk disease. And everybody was totally entitled to think that this was the case, because when we published our baseline demographics in the Lancet in 2014, people looked at these data and said, oh, 78% of Gleason 6, these guys are all low risk, and therefore, you know, no surprise that you're not showing differences in mortality. Well, that is not the case, because these are unpublished data, what I'm showing now to you, and in that we look very carefully at the risk categories, and the real risk category, taking into account PSA, tumor volume, and other factors, is 58%, not 77%. And we have a solid intermediate cohort of 40% in the 1,643 men that were randomized, and very low high risk. The second critique was radical treatment were old-fashioned. Most of the surgery was done using the open techniques. We used 3D conformal radiotherapy with neoadjuvant androgen deprivation, and we were also very criticized that these are old-fashioned and side effect profile should be better with contemporary treatments. And what was very, three things happened very shortly after the dissemination of our results. Now, you may criticize this study as much as you want, but it's the only randomized trial comparing open with a robot-assisted radical prostatectomy, and at least in the short term, it shows no differences between the 2 techniques. And then these 2 very large series looking at patient-reported outcomes in modern treatments, including brachytherapy, external beam, active surveillance, and robotic surgery. And if you'll remember the graphs I showed you on quality of life, urinary and sexual function and bowel, and you can almost superpose these new data of side effects from the 2010 onwards on 4,000 men treated in the US. There are no differences between the data we reported and the data reported in these 2 JAMA journals, and I wrote an editorial in the same issue. They make really good reading. The next are the 2 questions. Were baseline clinical pathological features of prostate cancer different in men who developed disease progression compared with those with stable disease? And here are some interesting data. If you look at baseline characterization of these patients, so we had 204 patients who progressed versus 1,439 who didn't progress. And this includes the deaths, prostate cancer-specific deaths. And you can see that 53% of the ones who progressed had baseline of 3+3 Gleason, 28% at 3+4, 14, 4+3, and 5% more than 8. But look at the ones who have not progressed. We had 15% 3+4, 3% 4+3, and even 1% more than 8. Now, this is not the whole story. These are some intriguing, the numbers are small, but there are some intriguing findings. This is trying to stratify the patients according to progression or no progression. So if you look at the Gleason 6, there is a difference between radical treatments and active surveillance. If you look at Gleason 3+4 and 4+3, they are different in that surgery seems not to help these patients. Again, difficult to make conclusions, but radiotherapy seems to have an advantage here, and the same applies to Gleason 8. These are just early observations, and we'll see what happens over time. The next question was, were surgical pathological features different in men who developed disease progression compared with those who did not progress? And this is why I said that the story of the Gleason 6 is not finished, because none of the men who had pure Gleason 6 on pathological staging, out of all the ones who received surgery, 391 out of 553, remember it was an ITT, intention to treat analysis, none of them developed any disease progression. Now, does that mean that 6 never progresses? I can't say that, but what I can say is if you have a 6 and you have surgery, nothing's going to happen to you. You're going to be cured. That's all we can say. But again, look, we've got in the no progression, men who received radical prostatectomy, you can see the ones who are cured, 10-year median with a range of 7 to 15 years. 42% of the 3+4 of them were 3+4, and 5% 4+3, and we can even cure with monotherapy patients with high risk. So the new PROTECT messages beyond the ones that we've published, and we have a number of manuscripts in preparation and submitted. PROTECT randomized cohort represents low and intermediate risk. The risk stratification at diagnosis at baseline is inaccurate, and you might say, well, you didn't do imaging, now you're going to use imaging, it's going to be better, you're going to have fusion biopsies, it will improve possibly, but what we used at diagnosis was not good enough. Patient-reported outcomes are similar to modern treatments, so our data are generalizable, even though we started to randomize in 1999, and longer follow-up is essential to see whether the mortality curves are going to separate or whether competing morbidity is going to overcome that. And patients will have an oncological advantage of having less metastases but will not die of the disease. Time will tell, and we're fortunate we just had our study extended for follow-up to July 2021. Now, just a few words. I don't want to keep you from lunch, but just a few words on other areas. Focal therapy, partial ablation. John gave a very elegant description of why this is being looked at, so I won't dwell. And this, he alluded to this first phase 3 RCT and the differences between the patients who received VTP versus the ones who received active surveillance. These were really low-risk patients, and my view is that it is a pity that it was really the wrong cohort, because I don't believe that you can judge progression over a period of 2 years in low-risk disease. Biopsy findings do not necessarily mean progression. So we're putting another smaller grain of salt here, and we've completed a feasibility study looking at can we offer organ preservation to men with unilateral, dominant, intermediate risk disease, so Gleason 7 and more. And this is the protocol that we followed. A pre-biopsy multiparametric MRI, followed by targeted biopsies and systematic biopsies as necessary. Then the patients consent if they are suitable, i.e. if they have dominant disease on one side with minimal disease on the other side. If they have bilateral intermediate, they are excluded. Then they are randomized to either radical prostatectomy or partial ablation. The methods we've used in HIFU was one radical treatment option, surgery, so that we have full pathological staging, and one minimally invasive technology, and we used HIFU in this instance, and patients were allowed 2 consecutive treatments. The primary endpoint was treatment failure, but the definition of treatment failure is different in the 2 arms. In the radical prostatectomy arm, it's about the need to receive secondary treatment, like radiation, and in the partial ablation arm, it's the requirement for total gland treatment. So we completed the feasibility and submitted the report, which is going to be published soon. We randomized 87 men. These are their demographics, which come as no surprise to you, but you can see we've made no discrimination. We got 3+4 and 4+3 patients. And these are snapshot results, which again you would expect. These are incontinence scores, surgery versus HIFU, urinary bother score, no significance here, erectile function between the 2, and a physical well-being score. And this is, again, a snapshot result of what happens to the PSA. It's early days, and the plan now is to go to a major trial. We have a deadline in January to submit a major phase 3 RCT comparing radical treatments with any technology which produces adequate partial ablation in 800 men over a period of 4 years. I'm going to finish with our Achilles heel, which is the genomic diversity of prostate cancer, which I think is at the root of many of the controversies and the difficulties we're having in making decisions to treat these patients. I'll remind you of an article which is now 4 years old, where the authors took one patient, started age 47, and followed him up for 17 years and managed to take biopsies from every site of the disease as the patient was managed and treated. And they found eventually that the clonality of the cancer that killed the patient was similar to the least aggressive clonality in the original primary prostate. And this stirred the whole community. And this is now emerging, and there are many papers, I just picked a couple. This is looking at multifocality of cancer and clonal expansions in 3 patients only. And the bottom line here is that there were mutations which were found at high levels in tissue which was morphologically benign and distant from but shared by the cancer. And again, that tells us how little we understand about the composition and the genetic composition of cancers. So what are the remaining big questions? So we heard a lot about screening, and it has to become a multimodal targeted risk stratification. So we need to discover more and understand, particularly the pre-biopsy space, and validate in archival cohorts and biorepositories, but mostly in men where we have long-term follow-up and in men who did not necessarily receive treatment. The diagnostic pathway is changing, but it must change more if we want to avoid over-detection of indolent disease. And we had some very elegant talks about imaging, and Peter said quite a lot about pre-biopsy, liquid biopsies. Tissue diagnosis must be guided by refined and exquisite imaging, and that requires innovation, engineering, and prospective evaluation. Digital pathology and multiplex tumor analysis must replace the conventional microscope and complemented by genomics. Partial ablation needs to be evaluated properly in RCTs if we want the answers. Precision surgery, Dr. Lodon explained very nicely the potential place of intraoperative imaging during the surgery, and there are some very exciting developments which are ongoing. Undertreatment of high-risk disease must decrease by evaluating multimodality therapeutic approaches up front, and this will require physical, immunological. We really are miles behind understanding the response of the immune system to the cancer and the response to the physical treatments, including the abscopal effects. Some work is being done on oligometastatic disease, but we're a long distance from understanding what's happening. Drugs and small molecules and radiation, including small particle therapy, which again is not being evaluated properly, and that required RCT. I'm going to share with you something really exciting that we are trying to build. Is a major global platform, and we are trying to apply for major funding for that. And the name of the consortium is called PROPEL, or Prostate Cancer Profiling and Evaluation of Lethality. And this is about discovering features of lethality in men where we have annotation and very clear phenotype. It's about understanding the mechanisms of these discovered pathways in preclinical models, and using also the immune system and microenvironment, validating this in archival cohorts, and setting up an early detection program globally. And we are trying to cross 4 continents with so far centers involved in the US, Africa, the Far East, and different parts of Northern Europe. So I hope this is going to be not just a dream but a reality. Some of you here are involved with this, and we have more partners in the US, and I hope this will continue to grow. And I'm going to leave you with the sun setting on the dreaming spires of Oxford. This is one of the reasons why I moved there, is because these spires are trying to go beyond and converting dreams to visions to reality. So thank you very much indeed.